It's not gonna look weird that Crystal just jumps in.
Yeah, she's just gonna randomly appear. It's fine.
Just just asking. Okay.
All right. Welcome to another episode of the Breaking Barriers podcast. I am Gina Polisek and will be your host for this episode. I am joined by my co-hosts Kelly Peterson and Crystal Simpson. Today, our guest is Dr. Iverson from University of Kentucky Children's. Dr. Iverson is an ENT and has been on previous episodes. Today, he joins us to discuss the topic of apnea. I will now hand it over to Dr. Iverson to give a brief introduction before we get into our conversation.
Excellent. Well, thank you, Gina, Kelly, and Crystal, who I'm sure will be joining us shortly. But I just want to thank you again for this opportunity to be on the podcast and to kind of share what I know and my passion for taking care of kids and kids with trisomy 18 in particular. And again, so I'm a pediatric ear, nose, and throat physician, boarded in otolaryngology, so ear, nose, and throat, as well as a complex pediatric otolaryngology sub-certification. I am the chief of pediatric ENT here at the University of Kentucky, also serving as the vice chair for clinical affairs within our department. So I've been here for 10 years and got to meet a lot of amazing folks through this process, specifically, Crystal, and Gunnar through that 10 years that I've been here. And then from there, I've been able to meet you guys and be involved with this there. So again, just a very exciting thing for me as well. So thank you again for having me.
Yes, we're
Thank
very
you for
glad to
coming.
have you here. We know that you take wonderful care of Gunnar, and we're happy that you can share your knowledge with the entire trisomy 18 community. So to kind of kick this off, could you explain the various types of apnea and how often they are seen in people with trisomy 18?
Sure. Yeah, so just to kind of talk about the different types of apnea, what is apnea? What is sleep apnea? So um, sleep apnea really is a cessation of airflow while sleeping for a period of 10 seconds or 2 breath cycles. So when you think of kind of your natural kind of rhythm of breathing while you're sleeping, if you have basically where the air doesn't flow through your nose and mouth into your airway, into your lungs, for that period of time, either 10 seconds or 2 breath cycles, that's what's considered an apnea. Now, there are 2 major categories of apnea, because apnea can either come from either the brain is not triggering those breaths. So that's called a central apnea. The other type of apnea is what's called an obstructive apnea. So that's where there's an effort, where the brain is making an effort to trigger a breath to breathe, but yet there is some degree of collapse or obstruction of that breath into the airway, into the lungs. And then there can be very often a combination of the two. Specifically in children with trisomy 18, we see obstructive, we see central, and we see kind of a mixture of both. And I just want to preface this by saying I am not by any stretch of the imagination a certified in sleep medicine or like a sleep pulmonologist or anything like that. Certainly my area of expertise is more in the surgical evaluation and intervention for children with sleep apnea. So I just want to be clear on that. So if
Mhm.
just certainly there could be more detail, but this is kind of what I've learned and what I know and how I use this information kind of for my practice. But just wanted to qualify there. But so yes, so mixed apnea is very common, and then sometimes obstructive apnea can over time lead to a central apnea, because it kind of changes your set point for breathing. So in general, when we breathe, the reason our brain triggers a breath is because levels of carbon dioxide kind of build up in our bloodstream, and that's what triggers that breath so that we can kind of breathe off that carbon dioxide, get in oxygen. Now, over time with sleep apnea, that sensor, that thermostat in our brain that triggers the breath can be less sensitive to carbon dioxide, just because we're used to that carbon dioxide building up and building up. And then it can change more to a central sleep apnea. Also, we get more of an oxygen dependent drive to breathe, which is where, rather than higher levels of CO2 where we breathe, it's the oxygen decreasing starts to trigger a breath. So there are some changes that can occur in sleep apnea over time. And to answer the question, as far as, is apnea commonly seen in children with trisomy 18? And the answer is yes, it's quite frequent. I can't think of a patient who, I've seen with trisomy 18 who we have not been dealing with this on one level or another, some degree of severity or another. So it's very prevalent.
Yes, definitely. I mean, I know all three of our kiddos have sleep apnea, different forms of it with different treatments and whatnot, but
Sure.
it's definitely very prevalent, I would say. Obviously it's a very large spectrum. So we know of some that don't have sleep apnea, but the general consensus is that most do.
Yes.
So kind of leading into that, could you explain how sleep apnea differs in pediatrics versus the adult world?
Yeah, absolutely. And this, honestly, when I was learning about this, I've been doing this for 18 years now, but kind of early on when I was learning, I was like, wow, there's a difference between kids and adults, because there really is.
Yeah.
And so, what I was talking about before was that number of times that you have the pauses in your breathing, or for the 2 breath cycles, that's called an apnea. But there is also something that's called a hypopnea. So a hypopnea is where you don't completely stop with your breathing, but there's a reduction. Some will say 30%, some will say 50% in the airflow. And then many times that can be associated with a drop in oxygen. So that is a hypopnea. So what we're looking for are the number of apneas and the number of hypopneas per hour of sleep. So that's kind of it's called the apnea hypopnea index. So we take those events that occur over the amount of time that a child is monitored with sleeping, usually during a sleep study. That's divided by the number of hours that are slept during that sleep study time period. And then that's where you get that apnea hypopnea index. Now, I'm just going to speak to the adults first, because that just kind of gives you an idea. So if that happens, Gina or Kelly, or and you or in me, if it happens 15 times an hour, basically if we have that pause in breathing or a reduction in breathing 15 times an hour, that's what is considered sleep apnea for an adult. Now it does decrease a little bit if we have symptoms such as, like, if we're tired all the time, we've got cardiac issues, high blood pressure, things that sleep apnea can affect, attention issues, poor concentration, those types of things. So if we have sleep apnea related symptoms, then if we have an apnea hypopnea index of 5, well, then that's considered mild in an adult. But otherwise, it's not really until you basically stop breathing 15 times an hour, which, that's kind of a lot, right? I mean,
It is, because we're what, 12 to 20 for adults.
exactly. And so, and then 15 to 30 times an hour is moderate, and then more than 30 is severe. So that just kind of sets the stage for adults. Well, now in kids, we bring that threshold down so much lower, where we give kids basically 1 time an hour to have that apnea or hypopnea. So anything more than 1 is technically considered mild sleep apnea. So 1 to 5, really 4.9. So then if we have 5 to 9.9, that's considered moderate. And then if we have 10 or more in a child, that's considered severe. So, that threshold of that bar is very much lowered in children, and we want to treat them differently. And the reason why is because, children are growing, they're learning, they're developing. During growth phases, so much of our growth hormone is secreted during our sleep cycles. So if we have interrupted sleep cycles, it can actually interrupt growth hormone production in our body that actually aids in kind of that growing. Certainly it affects mood and concentration, learning. So of course, kids are sponges, they need to be learning and growing and developing, so much more. And there's a lot more of that going on developmentally. And so that's why we set that threshold lower, so that those things can be kind of optimized as far as growth and development. So those are the main differences just in the sleep apnea for kids versus adults.
Yeah, it's crazy how it differs so much, but it makes sense overall, with the developing brain and everything,
Correct.
for it to be a lower threshold to treat. So with that, what is kind of like the gold standard for diagnostic tests or procedures to confirm sleep apnea?
Yes. So polysomnography, that's kind of the technical name for it, or a sleep study in a lab. It's really the only validated method to diagnose sleep apnea in children. People may have heard of like a home sleep study test for adults, and that can be appropriate and evaluated for adults. But in children, really the only way to diagnose sleep apnea in children is with what we call an overnight polysomnography in a sleep lab. I tell folks it's, you come to a hospital-like room. I'll tell them it's not really a hospital room. Ours is in the children's hospital, but it's separate. It has more of a regular type bed than a hospital bed. And I tell folks it's not like the Ritz, but more like a Motel 6,
Yeah.
And many times I'll tell folks that it's a sleep study, but for parents, sometimes it's a no sleep study. I don't know if you've been there. There's a lot of kind of adjusting, and sometimes it can be tough to get kids to go to sleep because, I tell them nothing hurts. But what we do, the reason why it's called polysomnography is multiple things are being measured during that sleep study. And so kind of the first thing, I'm just kind of go from head to toe. First thing that's being measured are brain waves. So there's EEG, electroencephalograms, that are being used. So you've got kind of these stickers on the forehead that monitor brain waves. And that is for monitoring basically the different stages of sleep. As we cycle through stages of sleep, you can see brainwave changes, even into that REM sleep, which is the rapid eye movement sleep, which is that sleep where we dream. And interestingly enough, the brain wave pattern of when we're in our dream sleep is the same exact brain wave pattern that it is when we're awake, essentially. And so that's why we know that that's where we're dreaming, because our minds are active. Now, other things that can happen during that sleep is, different muscles relax. So we have basically most muscles have some degree of tone until we get to that REM sleep. And there are only a few muscles that do not have any tone. And those are your extraocular muscles. So the muscles that move your eyes, that's actually why it's called REM sleep, rapid eye movement sleep. So your eye muscles are moving. There's some small muscles in your middle ear that remain active with tone. And thoughts for that are like, well, hey, if you're in a deep sleep, your ears are kind of still listening out for, things that may pay attention to. The other thing that is moving is your diaphragm. So the diaphragm is the main muscle that contracts rhythmically below your lungs, basically, in order to kind of expand and contract those lungs to kind of maintain your breathing while you're asleep. But essentially every other muscle in your body will relax and not be functional. And so I don't know if you've ever had sleep paralysis before, but it's a scary thing where you kind of, you can kind of wake up and you're kind of awake, but you can't move your muscles in your
Move.
body.
Yeah.
Yeah. So
Scary.
I mean, weird things happen, we don't know why necessarily, but weird things happen when you are asleep. So, so from that, we're measuring the breathing. Okay. So that basically chest wall movement is being measured during the sleep study. Your heart rhythm is being measured during the sleep study. You're monitoring your pulse ox, so your oxygen saturation. You're measuring end-tidal CO2, which is basically the amount of CO2 that you're breathing off. That's with a little kind of cannula in your nose.
Mhm.
Also, that helps measure air movement, so airflow. Because that goes back to how we measure an apnea is based upon that airflow. And there's also kind of some EMG electrodes that are on different parts of your body, like your legs, that help measure kind of other types of muscle movements. Restless leg type of syndrome can be monitored or evaluated during the polysomnography. So I think that's pretty much it. But so those are all the things that are being measured during that sleep cycle. And essentially most sleep studies need an 85% efficiency, which is where you have, out of the time that you're kind of lights out to lights up to lights on, is that 85% of that time is being spent in those sleep stages, so that you can kind of see, cycling through the different kind of stages of sleep into the REM sleep. Usually that REM sleep takes about 90 minutes for that first cycle to kind of come through. So so that's what's being measured and monitored. And yeah.
So what is it called when when you fall asleep and you do like those weird those jerks? Like almost like you're falling off of like a mountain.
Right. Well,
What
certainly
is
the
that
legs,
classified as?
it's the restless leg, movement
Okay.
stuff. So
Yeah.
yes. Mm-hmm.
I do that all the time and it like scares you awake.
Right.
Oh.
Right.
Hopefully you don't get the restless leg syndrome where your legs don't stop.
Yes. Yes.
Right.
Yeah. That's right.
So what are the treatment options for pediatric sleep apnea, and how are those typically determined, like the best course of treatment?
Sure. And so, certainly there's a range of treatment options for sleep apnea, and a lot of it depends on really the severity as well as the type of sleep apnea. So, you know, very simple things can be, I'll just kind of start with like non-invasive things, working all the way up to invasive types of things. So, certainly it can be as simple as putting on a little oxygen, even having a little bit of flow in your airway, kind of maintaining patency of the airway can be helpful for sleep apnea, for obstructive sleep apnea, even central sleep apnea. Certainly things like CPAP or BiPAP, CPAP stands for continuous positive airway pressure. So where you have typically some collapsing of the structures in your nose and throat, what the CPAP does is provides a continuous column of air, just basically air holding open that airway to prevent obstruction. BiPAP is similar to that. So it's like a biphasic positive airway pressure where it's basically CPAP, but then it'll either put on a rate or it'll kind of trigger when you trigger a breath, just depending on the type of sleep apnea that's being treated. But you have that basal rate of a column of air, but then when you're trying to breathe in, it'll give an extra boost to that breathing. So sometimes it can even kind of help with the cycle of breathing rather than just simply maintaining a column of air. So in some instances, there can be medical options for treating sleep apnea. Some validated medical options can be like a nasal steroid, where you can reduce inflammation in the nose, to open up the nasal airway passages. There can also be things like montelukast, which is a medication that is given for asthma. It's a leukotriene inhibitor. Basically, it helps reduce inflammation. So I think of it, and I tell folks, it's kind of like a strong allergy type of medicine. But what that does is it can reduce inflammation and open airways from a medical standpoint using that medicine. And that can help with mild or residual sleep apnea. But then when we're dealing with kind of a more moderate or to a severe sleep apnea, we really look at, is there anything physically obstructing that we can address? So certainly the most common thing that people think about are tonsils and adenoid, and that's probably one of the most common surgeries that I do in my practice, are taking out tonsils and adenoid on all sorts of children. And so that's certainly many times like the quickest way to get an increased, airway, reduce that obstruction, because those tonsils, especially when kids have kind of dynamic collapse of their airway or low tone of the airway, those tonsils can just drop into the airway, obstructing. So tonsillectomy, adenoidectomy, certainly various surgeries that look at opening up the nasal airway. So sometimes turbinates can be enlarged. I've seen kids with just their nose is not, they were born with a nose that just didn't open up all the way, either in the front or in the back. And sometimes there are surgeries that can be done to address that. Sometimes you can have what's called lingual tonsil hypertrophy, which is a tonsil that sits on the back of your tongue. And sometimes that tonsil can be large and kind of blocking up the airway. Sometimes you can have floppiness, and I think we'll get into this later, floppiness of your airway, like of your voice box, called laryngomalacia. And that's basically where the structures that are involved in swallowing and protecting your airway can be floppy and also obstruct. The other thing that you can see is sometimes kids can just have like very narrow airways, where their mouth is small. Their facial development is smaller. They can have like a narrow palate, or they can have a small jaw. And with that small jaw, it can, the tongue is actually connected to the jaw. So if that jaw is small, set further back, the tongue then, is set further back, especially when kids are sleeping on their back, that tongue can just fall back and block the airway. So there are surgeries that are, that can be, designed or created or utilized in order to kind of move jaws forward. These are certainly more advanced types of surgeries. Move jaws forward, move the tongue forward, rearrange tissue in the back of the throat in order to help with that obstructive airway, or trim up tissue of a floppy voice box as well. And then ultimately kind of the end kind of surgery that is done many times, where basically everything, either we don't think kids are going to tolerate other procedures, or there are other lung issues going on, or just if there's not another good solution, and that's a tracheostomy. So tracheostomy bypasses all the stuff up above in the nose and throat and just goes directly into the windpipe. And that in and of itself is a way that bypasses all other levels of obstruction. And certainly with central apnea, where the brain's not triggering a breath, sometimes that is kind of the ultimate, procedure that's necessary, not just to bypass obstruction, but so that, there can be a ventilator that would actually initiate those breaths and breathe for that individual. Since that's not something that would be triggered by the brain in a central apnea situation. So that's my long answer to that. That's my short answer to that.
There's moral of the story is there's a lot of treatment options,
Right.
which is great. I know that tonsillectomies and I struggle saying this word, but adenoidectomies are, pretty common with trisomy 18. We see kiddos having that done often.
Right.
What are your thoughts on those? Do you feel that they really benefit people with trisomy 18? What have you kind of seen in your practice?
Yes, certainly if the tonsils and adenoid are enlarged, that's certainly kind of the biggest bang for your buck that you can get, so to speak, where you can do something, certainly the tonsils and adenoid, they are part of our immune system, but we have plenty of other tissue that do the same job that the tonsils and adenoid do as part of our immune system. But there's certainly things that we can function very well without, I guess is what I'm trying to say. But also, many times those can be enlarged, especially when you think about the relative size of them compared to folks that have, smaller mouths, smaller throats, smaller craniofacial structures, because certainly that is something that we do see quite commonly in children with trisomy 18, is that they have the micronathia, microcephaly, so smaller mouth openings, narrower palates. They've got more of that hypotonia. And so anything that we can do to kind of open up that space does help improve that airway. And the tonsils and the adenoid, they're a tried and true way to address that for sure.
And how does sleep apnea, I know you've kind of briefly touched on this a bit, but how does it differ in children with, conditions like trisomy 18 versus, other, people in managing sleep apnea?
Yes, so, certainly differs in that, as I was saying before, there are those other anatomic considerations that we do need to take into account where we're dealing with smaller craniofacial structures, spaces, and then also that tone, where many times there's more of a hypotonia. Sometimes reflux can be more present, floppiness of airway, just floppiness of kind of the sidewall collapse of the pharynx or the hypopharynx, which are basically the walls of the throat. So those are things that we see more commonly in children with trisomy 18 than we do in typically developing children that have sleep apnea. And a lot of times, sleep apnea can be related to more of a weight type of thing. So children who are obese certainly would have be more prone to sleep apnea, but I would say in my experience that's not necessarily the case in children with trisomy 18. That's the case. It's more of a kind of a tone and a structural type of reason as far that plays into their sleep apnea.
I also wanted to mention too, I know you mentioned Malaysia a bit earlier, but for those that are listening, so we're actually doing a whole nother episode with Dr. Iverson specifically on trachs in Malaysia. So we're not going to probably touch on it too much on this episode. So if you are listening and are interested in that, look out for that other episode that we'll release as well. So kind of going back to what we've been discussing, what age do you feel, children specifically with trisomy 18, should be assessed? When should their airways be assessed? At what age would you feel is best?
So as far as their airway being assessed versus a sleep study, or just
I guess both really.
Okay.
If you could hit on,
Sure.
the airway assessment with scoping and then also a sleep study.
Yeah. Well, as far as their airways being assessed, I think that's something that's kind of done from birth, honestly. A lot of times we'll see folks in the NICU who have been diagnosed with trisomy 18 and they're either, on a ventilator, intubated, or they may have some CPAP going on, or BiPAP, or even oxygen. And many times we'll get a request to evaluate them in the NICU to come in and do a scope when they're, shortly after being born, even sometimes, just kind of assessing for other, types of structural things that could, help wean off of oxygen, help wean off of CPAP that we could address. So I think earlier is definitely better from that standpoint. As far as and then, as kids grow, we're kind of continually reassessing, because tonsils and
Mhm.
adenoid are not big at birth, right? Those don't get big until later in childhood, once that immune system has had time to kind of respond to things in the environment. And those tonsils, I tell folks the tonsils have a chance to work out and get big and
Mhm.
be more prominent. So those are certainly not seen right at birth, but can be developing over the first few years of life. As far as getting a sleep study, there really is no, to my knowledge, amongst clinicians, like a specific time at which a sleep study is recommended to be obtained for children with trisomy 18. I think in general, we see that happen anytime from probably a year on. And sometimes it's ongoing and multiple sleep studies are done. And sometimes it's repeating a sleep study every year. There is a general consensus in, children with trisomy 21, that there is a recommendation to have a sleep study if you haven't had one by age 4. But that recommendation really just doesn't exist in the general, overall literature, at least to my knowledge, at this point in time for trisomy 18. And a lot of it's just kind of guided by, you know, by, children's needs for support, for oxygen, CPAP, whether or not they're able to wean from that, guided by symptoms, snoring, witness apnea, turning blue, these cyanotic episodes, many times feeding is involved, growth is involved. So kind of looking at all these things together to decide, along with families, when's an appropriate time for a sleep study. And the other thing to mention too is that not all centers can do sleep studies for all ages.
Mhm.
10 years ago, when I started at the University of Kentucky, they could not do a sleep study on anyone under 18 months of age. We had to send them out. And so that was just kind of a hospital policy. But there has since been, growth and development in that program. And certainly programs at other institutions where, so now we can do sleep studies basically at any age. But so those are other, sometimes limitations to getting a sleep study.
Yeah, that makes sense. I feel like there's so much going on for a lot of these babies too that it's hard to kind of navigate, what to do when you got the heart involved and,
Right.
so many different things. But certainly it sounds like the general consensus is as early as possible, especially if you are seeing, signs and symptoms. So
Right.
kind of going off of that, and I know again, you kind of touched on this already, but what signs and symptoms specifically should parents, kind of be looking out for to, maybe
Mhm.
push for a sleep study or further scoping to be done if, they're seeing those at home with their child?
Yeah, absolutely. So, if we're not weaning from oxygen or CPAP, those would certainly be some things, but just other things that you see kind of developing, an absence of that, would be, snoring. So snoring to the point where, you know, basically there's a pause or a gasp. You can kind of even see that 10-second pause sometimes. And many times I'll ask families just to bring in a video. I'll say, hey, take some videos of your child sleeping just so I can take a look at it. And certainly that's not a sleep study or a substitute for a sleep study, but I think it's just helpful to see, if you see that happening. Many times I'll ask kids or ask parents, do they scare you while they're sleeping? It's because many times we'll get the answer of, yeah, they snore and they stop breathing. I wonder if they're going to start breathing again. And so those are other things that, definitely if we're having that, we need to evaluate the airway, evaluate with a sleep study. Cyanosis, so kind of blue spells, that type of thing. And certainly depending on the on the cardiac status of a patient with trisomy 18 and whether we're in a repaired or an unrepaired state. I won't necessarily speak to any of that because that kind of goes beyond the scope of really what I deal with. But certainly there can be baseline levels of hypoxia or low oxygen and cyanosis, but certainly there can be cyclical things that you see during sleep cycles. Poor weight gain is another thing that sometimes we'll see. We talked about that growth hormone that's secreted. And the other thing that we also see is sometimes kids are just, they're working so hard to breathe that a lot of their calories go into breathing and not necessarily the growth. So those are other things to look for, as well as just, excessive daytime sleepiness or falling asleep easily. These are other questions that we kind of ask folks and to kind of gauge the level of of how much sleep apnea we may or may not have, or how aggressive we should be at looking into it more.
Do you feel that babies are going home from the NICU with appropriate support in many of these cases, as well as even, children that have been discharged from the NICU and, things may be arising? Do you feel like they're getting appropriate support, from this area?
Mm-hmm. Yeah, thankfully at our institution, I feel like the answer to that is yes. I can imagine that in some places that may not be the case. I would say we're fortunate where we are and where a lot of folks are, especially with kind of tertiary and quaternary referral centers, that yes, there's a lot of great support. The NICU is very involved. They get us involved early and often, and there are other like NICU grad type of clinics or complex care clinics that are available, especially with what we have at the University of Kentucky. There's a whole complex care NICU grad clinic that provides a lot of support and just they spend probably a couple hours with each patient visit interaction, just kind of assessing, the whole patient needs, family needs, all those things. And many times we become a part of that assessment and working things up further. So I would say yes, it can be done, and it can be done very well. I can speak to our institution and any institution I've been in where it has been done well, but certainly I can see that there might be challenges just depending on what area you are or which center you're in. So but thankfully I think for the most part they're pretty good referral patterns to places where they have the capability to do that. So
Definitely. And I feel like too, that's why it's important to get knowledge out there too, so parents know more. Because if
right.
you just don't know, you don't know what to ask for. And so I feel it's, important to get this out there so parents can, push for these things if they are in an area that maybe, it doesn't have the same advancements. So their kiddo can get somewhere that maybe does, or, get them to be willing to, if they do have it where they're at and they're just not willing. So yes, that's very helpful information. One question I did have was, so when it comes to tonsils and adenoids, so at what age do you usually see kind of the tonsils get so enlarged that they need to be removed from a child?
Sure. Yeah, 2 to 4 years of age are kind of the ages where I will typically and very commonly see that happening and developing, the need for that. Now I've seen it in folks who are older as well, but kind of that age range is many times when you see that tonsil tissue kind of build up and develop and hypertrophy, just get larger basically. And so the way I tell folks, like, why do we have tonsils? What's the whole point of these things? The way I postulated, this is just me postulating, right? So like, where does everything go in an infant? It goes to the mouth, like, right? Like that's the way that we are programmed to explore our world. So everything outside of the body first comes in through the mouth. So those tonsils are there. They're picking up foreign material. They're picking up viruses, bacteria. They're learning the immunity. So they're working on developing immunity where they produce antibodies or other infection fighting cells. to fight infections that come into our body. They're also creating cells that have a memory, to where if we're exposed to that same thing again, we can react to it and react to it quicker, and then, produce that infection fighting immune system response. So it's like all that it's coming in through your mouth or through your nose, whether you breathe them in, and the adenoid is kind of the gatekeeper to the nose. So that's where that tissue is located. So the first few years of life are really where we see, a lot of that being, developed and enlarging. So hopefully that was the answer to your question. But you can see it at any age, but I think, certainly in children with trisomy 18, we're assessing, early on, especially if we're kind of, tuning into the fact that, that sleep apnea is going to be, kind of something that we're going to need to address.
Okay. Yeah, and I guess a reason I asked too was sometimes we see in kids with trisomy 18 is, they go in to get their adenoid removed at like age 2 or whatnot, but their tonsils aren't yet enlarged.
Correct.
But then like maybe 2 years down the line, the tonsils are so enlarged that they need to then have those removed.
Right.
So kind of like, what is your philosophy in regards to like, would you generally take the tonsils with the adenoids, or would you do 2 separate surgeries in that situation? If, for a kiddo like that.
Right. That's a good question. And a lot of it is just kind of patient dependent, whether or not what we feel to be the most contributing factor to child sleep apnea. Like in general, if I can avoid taking out some tonsils until a child is 3, I'm usually pretty happy about that, because taking out the adenoid is fairly straightforward. We just go in, you shave it down. There's no capsule to the adenoid. You cauterize it down, you shave it down, multiple different methods, just gets it out of the way. Tonsils, they have a capsule to them. They've got a robust blood supply. Having your tonsils out is a much more difficult thing to recover from than having your adenoid out. Certainly there's a risk of bleeding. It's a 1% to 2% chance of having some bleeding, where it can be scary and you have to go back to the operating room to stop it. Kids don't bounce back from having their tonsils out as easily. So, if those tonsils are not large or not thought to be contributing to the sleep apnea, in general, I'm just not eager to put a child through that at a young age, and or assume some of those risks involved, unless we really feel like it's going to be a major impact in their sleep apnea overall.
Yeah, that makes perfect sense. And that's definitely good information to know. Also, low key, I think it's very interesting that it's adenoid, just singular and not plural, because I feel like everybody always says adenoids. So just wanted to throw that tidbit out there.
Yeah. Oh, I have a funny story about that if I have time to say it.
Yes.
One time I was talking to a family and to a mother of a child, and I was like, yeah, so we're gonna take out the tonsils and the adenoid, and she corrected me. She was like, the adenoids, both of them, and I was just like, yes, ma'am, we're gonna take them. Yeah, we'll do that. So, I wasn't gonna be like, wow, there's only one adenoid. So, but the truth is, there is only one adenoid pad. So, both sides of the nose, we've got that septum, which is the wall that separates the 2 halves of the nose. As we get to the very back, that septum stops, and then it opens up into one cavity back there in the back of the nose. And in the back of that cavity in the nose, we've got the adenoid that's plastered just right on that back wall. And then either sides of the adenoid, we have these basically folds of cartilage and some tissue that is the opening to that eustachian tube, that natural tube that drains from the ear into the back of the nose. So that adenoid pad sits between the eustachian tubes in the back of the nose. Now, the adenoid pad itself has like multiple fronds of adenoid tissue that kind of come off of that pad. So my assumption is that the adenoids plural comes from, these fronds of tissue that come off of that adenoid pad, but there is only one adenoid.
Yeah, I always find that really funny.
Mhm.
Do you feel that airway surgical intervention is continuing to improve as technology does?
So yeah, I think the answer is yes, but only more recently. Because I think the techniques that have been around to address sleep apnea, obstructive sleep apnea, have been around for a very long time. I mean, tonsils have been taken out since, Egyptian times, that I've
Yeah.
been able to read about. So tracheostomies have been done, since ancient times, certainly with a lot more, morbidity back then. But but as far as taking out tonsils, taking out adenoids, shrinking turbinates, I mean, improving the nose, improving the jaw, like these, taking out lingual tonsils, you know, there are other procedures where you basically screw a screw into the lower jaw and then loop a wire around the back of the tongue to pull that tongue forward. I mean, from a technological standpoint, these aren't really like advanced technological things. Um, but people kind of think about different ways how to use, just these long-standing surgical or technical type of interventions in order to improve the airway, and then ultimately trach, that's been around forever as well. I think the one thing that really, from a technological standpoint, and we'll kind of have to see where this one goes, and it's kind of exciting, is the hypoglossal nerve stimulator. Have you ever heard of this?
No.
So this is something, it's approved in adults right now. Um, and it's improved down to about 12 years of age right now in children who have trisomy 21. But it's for certain types of sleep apnea. So basically where there's glossoptosis, or where the back of the tongue falls into the back of the throat. And
Hmm.
that's assessed on what we call, we talked about scopes in the past. There's a sleep endoscopy procedure that we do while a child is, or an individual is asleep, with some anesthesia, trying to replicate natural sleep as much as possible. And you basically look for areas of obstruction. Well, if that tongue falling back into the airway is a significant part of that obstruction, there's a device that's implanted almost like a pacemaker, and it's got one sensor that goes down to the intercostal muscles, or the muscles
Hmm.
that are between the ribs.
Ribs.
Because as those expand, it senses, that expansion of the chest cavity. But then there's also an electrode lead that comes off of it, and it's implanted around the nerve to the tongue. So the nerve to the tongue is called the hypoglossal nerve. So what it'll do is it'll pace the timing of the breaths with stimulating the tongue, giving it some tone, so that tongue will kind of protrude forward during the breath cycle in order to kind of open up the airway. So that I think is a pretty cool advancement in technology,
That is.
that has had some good success. People have come off of CPAP from it. But I think, as far as, you know, how we apply that to younger children, and children who have other either trisomy issues or craniofacial type of obstruction for sleep apnea, that's kind of yet to be determined. So I think that's an exciting thing on the horizon in sleep apnea at this point in time.
Yeah, it's incredible what technology is advancing. It's a little scary, but also for things like that, it's amazing.
Yes, yes, indeed.
Um, so yeah, I'm happy you shared that. I know Mia's ENT, he he said he literally dreamt it. Some like tongue procedure that is
Mhm.
just becoming kind of out there. I forget what it's called, but I'm sure you've probably have heard of it. I just don't know it off the tip of my tongue, but No pun intended
No
there.
pun intended.
But yeah, it's just amazing the advancements and what
Yeah,
some of you doctors think up to, just help with sleep apnea. It's crazy to think like what 10, 20 years down the line is going to be like,
absolutely.
for
Yeah,
conditions like this.
that's right.
But on that note, do you have any other, topics or areas related to apnea, that you want to touch on before we end this episode?
Um, you know, as far as specific areas, I think we covered it. For the most part, I just will say, you know, that's just kind of especially specifically to trisomy 18. We're trying to balance, because a lot of times there are unrepaired heart defects,
Art. Mhm.
pulmonary hypertension, all these things, which certainly we want to be aggressive in treating sleep apnea, because sleep apnea can put more strain on the heart and those types of things. But certainly, those types of conditions can make surgeries more risky, right? So so there's just this balance of, being aggressive in treating the sleep apnea, but making sure that we're taking an appropriate risk benefit analysis to make sure that each individual child, each individual family understands this, and we're kind of, discussing things with the cardiologist, we're discussing things with the pediatric cardiac anesthesia, the surgical teams, and that treatments are not just a one size fits all, but
Mhm.
specifically based on the individual child's anatomic needs, severity, other comorbidities that are involved. And then it's a decision making that just has to happen between, the providers and the families, and just a lot of, like what we're doing here is just educating folks, asking questions so that, families can make the best decision for their children.
Definitely. Yeah, that's very good advice and information. I mean, it's definitely person dependent. There's no one size fits all
That's right.
for these things. And I mean, there's certainly conditions that are very prevalent with trisomy 18, but no one child is the same.
Exactly.
So it's critical that these specialties are working together and that it's a collaborative discussion amongst the doctors and the family, taking it all into consideration for each individual. So I'm very glad that you touched on that, especially as we end this episode. So that's a great way to end this. So again, thank you so much for your time, Dr. Iverson. We're glad that you were able to be on this episode. And again, for our listeners, we will be having him on another episode regarding trachs in Malaysia very soon. So please look out for that episode as well, as it definitely will tie into this one a bit. So thank you for listening, and we look forward to having you join us for our next episode.
Thank you all so much.